My name's Erin Dunbar. I direct the Piedmont Brain Tumor Center in Atlanta, Georgia. I specialize in neuro-oncology, palliative and hospice medicine, medical oncology, and a clinical trialist. In our 13th year here, we've been having a portfolio of clinical trials to try to meet the needs of any patient affected by a primary or a metastatic brain, skull base, or spine tumor. Really, it's my passion to help people live their best, longest life in their own artistry with their own agency. So nobody does anything to bring on a central nervous system tumor. They affect all of us in the prime of our life. And so the goal is to, with the most expert diagnosis, be able to identify their individual tumor, be able to come up with an individual personalized treatment, and walk the journey with them to help them live their best, longest life. Glioblastomas are a horrific malignancy that can affect people of all ages, infants, toddlers, children, as well as people in the prime of their life in their 30s, 40s, 50s, and up. And in the advanced ages, it does become more prevalent as you get older in the populations, not only in America, but all around the world. There's some epidemiologic data saying that it's becoming slightly more prevalent. We don't exactly know why. It may be environmental toxins or other things we haven't identified. But currently, there's no cause of a glioblastoma other than horrific doses of radiation like Hiroshima and Nagasaki, or childhood therapeutic radiation. But otherwise, it just attacks out of the blue. The U.S. population data around the world as well is about 1 in 5 people out of 100,000 individuals are affected by a glioblastoma across their lifetime. However, it's really important, I think of them as a family of diseases, because what a glioblastoma is a malignancy of a support cell that supports the tissue that makes up the central nervous system. So not a discrete nerve or blood vessel or water channel, but actually the stuff that holds the brain together, almost like the dry wood, the brick, the glue. And that's why glia, they're the support cells. And so glioblastoma is one molecular genetic subtype of really a family of malignant glial tumors. So we often call them malignant gliomas. When you add all of those up together, they're actually a large share of the malignancies across the world and in the United States. I consider each diagnosis a drama trauma because it really is for each patient and family. The nervous system has a lot of common generic symptoms and really accommodates a lot. We can see a tumor that is 6, 7, 8 centimeters in the brain, and it's unfathomable that the person didn't have symptoms. Or maybe it's a smaller tumor in a more sensitive or specific function area of the nervous system. But no matter how large it is when we find it, we know that there are microscopic cells beyond where we can see an abnormality on the images. But that general location of where the epicenter of those malignant cells codify the symptoms. But for a long time, those symptoms are really generic. Maybe none, maybe occasional headache or confusion. That is much more common to have been something else. But when it does present as an emergency, a lot of times it gets initially labeled as a stroke, partly because strokes are so much more common in the United States and around the world, but also as a kind of a common modern civilization, we know the symptoms of a stroke or of a headache or something like that. And so people will go and we think it's a stroke. And unfortunately, instead of a vascular emergency of broken or blocked blood vessels, it's really the insult and injury is the architectural disruption and the irritation from malignant tumor cells. So patients present with kind of focal or general symptoms. They present to a healthcare frontline worker. That could be a neurologist, a primary care doctor, but often it's an ER, or they have been transported emergently into an ER. Imaging is done, and we see something horrific that none of us want to see, and that is the presence of a very angry, very edematous, inflamed, often bleeding area that we know that something is there that shouldn't be there. We cannot do any blood test, any cerebral spinal fluid lumbar puncture test, or any advanced imaging to be able to get enough information to be able to individually, with high evidence, treat a patient. So 100% of the time, a patient needs a tissue biopsy. That could be expertly done with a needle or an open biopsy, but anytime it's achievable, we want to get out as many of those malignant cells and the dead and irritated and swollen tissue as much as possible. That becomes then something that makes the patient safer, more comfortable and feel better, improve their function, but also becomes the first part of their treatment. But that's just the beginning. So after we get a sense of what we're dealing with, I think about helping people live their best, longest life in their own agency in two equally important ways. Number one, what is that person's individual tumor, their molecular genetics, where is it located, how many areas of the brain does it involve, what is their general health, and coming up with an individual state-of-the-art, state-of-the-science plan. But that doesn't define that whole person's journey. So the other theme is them as a total person, their symptoms, safety, quality of life, family, caregivers, access to healthcare, their general health, their goals and wishes. But the backbone fundamental treatment is diagnosis and maximal safe resection. And then we study that tissue and get what we call molecular genetics. What were the missteps that made those glial support cells go from being healthy cells to malignant cells? And so that pathway of missteps is how we outsmart it, how we learn what tools to put in the patient and the treating team's hands. Who are the people we need to flank them? What is our strategy? So part is surgery or biopsy. The other fundamental tools are radiation, medicines, and other treatments, which it could include tumor treating fields. But I have to say that the incredibly important part of backbone treatment, upfront and forthcoming, are clinical trials and other leading edge treatments. Incrementally, that has been the single most important thing that have helped people live better and longer. When I started training and being a clinician in the brain tumor space, people with glioblastoma were living months. Now they're living many years, and a larger and larger population all the time are living longer and longer and longer. And it's those incremental gains, often done by clinical trials and other advanced treatments. There is just an incredible paradigm, which is people have to be well enough to want a treatment and well enough to get a treatment. So one of the historical disadvantages of treatments was that they were too toxic. They hurt the person worse than the tumor. And so we were not able to think about things like sequencing treatment. Well, what's the next treatment chapter? What's the next treatment chapter? Or we weren't able to combine treatments. And quite frankly, we just didn't have that many treatments. So now we're gaining in different modalities. We are having different versions of those fundamental treatments, different types of surgery, including now whether it's focused ultrasound or laser, or different types of surgery where we can remove more tumor tissue and preserve more healthy tissue, or different types of radiation. Now the radiation can come in different ways, can even be implanted in the brain, come from the outside, be liquid or nuclear medicine radiation, and then medicines. That's really my passion. So medicines can come now in all different ways. It could be a pill, an IV, a nasal spray, a patch. It could be implanted or instilled inside the central nervous system directly. And they can have all different types of mechanisms of action. Old-fashioned medicines were just things that went to rapidly dividing cells and broke the cellular mechanics, often in a destructive way that rendered healthy cells all throughout the body and those in the nervous system really injured and really damaged. Now, mechanisms of action are very specific, and we're able to target where those medicines go. One of the ones that I'm really excited is berubicin, one of the medications that I was privileged to be the first and long-standing accruer of an international phase 3 clinical trial. So this was really exciting, and even more impressive that it was able to be conducted internationally during COVID. So it was a phase 3 randomized controlled clinical trial, taking what would be one of the United States and international standard workhorse oral chemotherapies called lomustine. It has other brand names around the world, but that is a typical cytotoxic medication, not very specific, mostly going to rapidly dividing cells. And it was paired with a specific bioengineered fourth generation anthracycline, specifically meant to cross into the blood-brain barrier and specifically meant to target certain discrete mechanisms within glioblastoma and other malignant glioma cells. That clinical trial was very impressive for me on several folds. One, it was really well accrued to, and that's always a good sign of a good drug, a good clinical trial, and a good promising agent. Also, it showed rapid clinical response. I had patients that within a scan or two, already we could see that we were killing tumor, and the tumor was showing that it was being treated by that agent. Also, when we compared how the tolerability was, two things were really notable to me. One, the berubicin was as tolerable, if not better, than lomustine, a medicine that I give every day of my career. Very similar effect on the bone marrow, very easy to manage, did not have any unusual side effects to the skin or the body. Patients tolerated it very well. It was given in a peripheral IV. And the other thing that was really important to me is that the class of medications called anthracyclines are very well known for, number one, not getting in the brain without that specific bioengineering. Two, very cardiotoxic. Patients have elevated, injured muscle enzymes in the heart and the body. They have to have echocardiograms and EKGs. And we have to dose, reduce, or stop medications because of that toxicity. Another toxicity is neurotoxicity, like the sensation or function of the peripheral nerves or the central nerves. So those specific anthracycline toxicities were either not present at all or dramatically less. So that means that when we gave this medication to healthy young adults as well as advanced age, average health, or elderly or frailer patients, they were tolerating berubicin incredibly well. So in addition to comparable or less toxicity, rapid imaging responses, we also saw clinical responses. So we were seeing that patients were saying less headaches, less neurologic symptoms. I feel well. I like this treatment. I'd like to stay on this treatment. One of the things that was built into this trial is if patients had pseudo-progression on an individual basis, they could get medicines that calm down that inflammation, whether steroids or a medicine called bevacizumab. And so what is pseudo-response? Pseudo-response is often correlated with an effective drug, because if we get a drug where we want it to go and it starts doing what we want it to do, we can see, and the patient can often feel, that those tumor cells are dying, and that can be an inflammatory process. So we can see that on an MRI, and we can see that in the patient's symptoms. And so we saw that. It was incredibly manageable, and to me, that corroborated that this was an active agent going where we wanted and doing what we wanted. So for promising agents like berubicin and other drugs in the pipeline, what I think is really important, particularly about berubicin, is it showed to be favorable, it showed to be efficacious, even in the most unfavorable molecular genetic markers in glioblastoma. some of that are also found in other malignant gliomas in children, young adults, and adults of all ages, and has a lot of promise in other malignant tumors inside the nervous system. We think of the skull base, and the spine, and very important as a medical oncologist for all malignant tumors that metastasize to the central nervous system. So the paradigm in medical oncology for anthracyclines in particular is, if you want a cure, if you want long-term survival, anthracyclines are part of that backbone, whether upfront or in sequential chapters of the patient's therapy. But we've never had anthracyclines that could get into the blood-brain barrier before, or proven that they get into tumors like berubicin has. And so to me, that is incredibly promising, that we have an agent that we can continue exploring in different diseases, different age groups, in different combinations, and in different sequences. And so patients who have already gone through upfront standard therapy, we need well-tolerated other agents that we can continue to expand their treatment options. So I'm really excited about that. And the fact that patients will feel well enough to be on it and want enough to get it means that we really have a large group of people in America and around the world that could benefit from an agent like that. And that is what I call evidence-based hope. Awareness days are incredibly important. On a humanistic level, they're incredibly important for patients and families, and even families in memoriam, right? It's incredibly important. It's also important for clinicians to be able to be recognized, to feel support in the community for their vocation and what they've dedicated their life to doing. It also serves as an inspiration to clinicians and scientists to continue to motivate and stimulate and inspire us to continue working in that space. And it's incredibly important for other stakeholders like policymakers, healthcare engineers within our governments, legislative advocacy, those who do philanthropy or fundraising, people who are looking to where to invest. So it really brings all the stakeholders, research scientists, patients, and their families really focused on moving the ball forward to help even more patients live their best, longest life.